Hi, very good morning, everyone. We are on 25th of April 26, and today we have Dr. Anuj Maheshwari. He's a renowned diabetologist and metabolic physician, over 30 years of experience in the field of medicine. He serves as a professor of medicine in Hind Institute of Medical Sciences in Lucknow in India, and is a leading metabolic physician at Shri Harikamal Diabetes and Heart Clinic in Lucknow. Dr. Maheshwari is widely respected for his clinical expertise and commitment towards advancing the diabetes and metabolic care. He's talking about resistant hypertension and diabetes, a global perspective. Over to you, sir.
Thank you, Saurabh, for giving me this opportunity. I am sharing my slides. So hope you can see my slide.
Yes, sir. Can you make it on presentation mode?
Yeah, yes. Is it there?
Perfect.
Okay. So let me start. So today we shall be talking about the resistant hypertension in diabetes, global perspective. First of all, we must understand what is the resistant hypertension. BP, if it is not about reaching to the target, which is considered nowadays about 130 and 80 mm of mercury, despite taking the three drugs, which includes RAS blocker, dihydropyridine, calcium channel blocker, and diuretic at maximally tolerated dose, that is called resistant hypertension. If somebody is keeping his blood pressure control on 4 drugs, he is also considered as a resistant hypertension. The clinical nuance is that true resistant hypertension is difficult to diagnose because many people don't take the medicine properly. They remain with the poor adherence, inaccurate measurement of the medicine, and many of the times they also measure the blood pressure incorrectly. And sometimes the white coat effects also plays an important role because with which we cannot say that blood pressure is under control despite taking the medication. So it actually needs to proper out of office assessment to know that whether a person is really having hypertension or not, and it is controlled on taking multiple medications or not. So if we have a classification of the resistant hypertension, broadly we can divide into the two categories. One is the controlled hypertension. Controlled resistant hypertension is that hypertension which is controlled after taking more than 3 drugs, and this is mostly seen in the condition when persistent fluid retention is there because of the sodium intake, because of the increased sodium sensitivity, or sometimes higher levels of the aldosterone, and sodium and water retention plays an important role in chronic renal disease. On the other hand, there is another category that is uncontrolled resistant hypertension, which is because of the sympathetic hyperactivity. This uncontrolled resistant hypertension is that which is actually because of which is actually the resistant hypertension, which is uncontrolled despite taking the 3 or more medications, what already we have discussed in the previous slide, like RAS blocker, diuretic, and calcium channel blocker. And this is mostly because of the sympathetic hyperactivity, because 24 hours urinary metanephrines are at a higher level, tachycardia, heart rate variability is poor, and most of the time arterial stiffness, which comes to many patients with the increasing age, comes early in such kind of the patient. Like arterial stiffness comes usually 50 years or more than that of the age, but in such kind of the patient, those who develop the uncontrolled resistant hypertension because of the sympathetic hyperactivity, they develop arterial stiffness much earlier, maybe in 20s and 30s. And peripheral vascular resistance also plays an important role. So this is the way through which we can categorize or classify the resistant hypertension. 12 to 15% it is seen in the general population, which are apparently treatment-resistant hypertension in adults. 16.1% are seen in patients, those who are having the diabetes. It is clinic-based cohort prevalence in people with diabetes. 40.4% are seen in the CKD cohort, those who are having the diabetic nephropathy, markedly amplifies the burden. older age obesity, diabetes, CKD, and many a time OSA cluster with Western hypertension. So diabetes always makes it a high risk context, not a natural comorbidity. So why diabetic patients are difficult to control? Nephropathy is one of the important reasons of that because many of the patients who comes as a naive diabetic, they already have the albuminuria and CKD, which accelerate the sodium retention, volume expansion, as well as progressive loss of the blood pressure control. Autonomic dysfunction, which is most commonly seen in diabetic patients, especially in the Indian perspective, and it starts with the sympathetic overactivity or hyperactivity, and many a times we see that variability in the heart rate is lost, and that is the first sign of that. Nocturnal hypertension and non-dipping reflects this abnormal circadian blood pressure behavior in diabetes. Usually, we see that in night time, blood pressure falls about more than 10 mm of mercury. But if it does not fall, or if it falls which is less than 10 mm of mercury, we call it a non-dipping. And it is because of the autonomic dysfunction. And many of the times it is seen that many patients keep their blood pressure normal throughout the 24 hours, but there is no fall in the midnight or in the night time. They are on the higher risk of the adverse cardiovascular and outcome. Polyvascular risk could be in the resistant hypertension as a diabetes compound risk for the stroke, heart failure, renal failure, and atherosclerotic cardiovascular disease. The same office blood pressure reading carries greater prognostic weight in a diabetic patient than in many lower risk hypertensive populations. Why does it matter in the diabetes? Because 64% of the cardiovascular outcomes, which are because of the higher incidence of the composite cardiovascular outcomes in apparent treatment resistant blood pressure rise. And 1.95 is seen in the kidney failure hazard ratio, where we see that hazard ratio for the kidney failure in all had trial analysis. 1.95 means more than 95% patients were found to be having difficult to control hypertension or resistant hypertension, those who were having the kidney failure. Two times cardiovascular risk they carry, and it has been confirmed with the ambulatory blood pressure monitoring that true resistant hypertension when it is compared with the treatment responsive hypertension. 43 to 65% people have the non-dipping. Prevalence of the non-dipping in resistant hypertension is that which adds independent prognostic concern. And many of the time, as I already said in the previous slide, that people, those who are having the normal blood pressure throughout the day, less than 130/80 throughout the 24 hours, but they are not having the non-dipping, they are carrying the high risk for the cardiovascular adverse outcome. So resistant hypertension is not just high blood pressure on many drugs, it is marker of the heightened cardiovascular and renal vulnerability demanding structured evaluation. So what should we do before labeling a patient resistant? We must ensure whether the adherence is properly or not. Because many of the patients are labeled as a resistant hypertension because of the poor adherence. 31% prevalence in apparent treatment resistant hypertension is large pill burden because of the large pill burden that contributes is primarily. White coat effect means white coat hypertension in which you will see that high blood pressure is only recorded when patient is in the doctor's field because of the atmosphere, because of the anxiety which remains in the doctor's clinic that causes 29 to 39% of the 28 to 39% of the resistant hypertension patients. And it is office blood pressure alone, many of that call time overcalls resistant. Measurement errors are also responsible for resistant hypertension, or we can say the falsely labeled resistant hypertension, like wrongly used cup size. Many people are having overweight and obesity, and they need a appropriate cup size for them, but it is not appropriate, and in that condition, they are they are recording the high blood pressure. Validated devices are not sometimes devices are not appropriate. Sometimes the readings are not taken properly. There has been a method of measurement of the blood pressure, especially in the home blood pressure monitoring. Recently, Indian Society of Hypertension has released its guidelines for the home blood pressure monitoring, in which it is said that what could be the correct position while recording the blood pressure, what could be the blood pressure readings should be taken, three readings should be taken at least 1 minute interval, and they should the first reading should be discarded, and remaining two readings should be used for getting the mean of the blood pressure, and it should be done by the validated automated office blood pressure monitors, which is almost closer to the ambulatory blood pressure monitoring as compared to the manual measurement. So failure to use the ambulatory blood pressure monitoring many of the time miss the white coat hypertension diagnosis for true resistance. But if we can use the automated office blood pressure monitoring, of automated home blood pressure monitoring with the automated oscillometric blood pressure monitor, many a time we can get and diagnose the patient of the white coat hypertension. Major secondary causes also remains there, which are renal causes, endocrine causes, sleep-related like obstructive sleep apnea, which is having the prevalence 60 to 84% patients, and because of the increasing weight and obesity, it is continuously increasing. Drug and lifestyle means many people are using injudicious NSAID, injudicious use of the steroid, sympathomimetics, excess alcohol, obesity, and high sodium intake in food, and various other things in which they use high level of the sodium salt, and it ends up with the secondary cause of the high blood pressure. High yield diabetic etiologies that include the diabetic nephropathy, hypertension is both cause and consequence of the CKD. So it is very much needed to assess the creatinine, EGFR, albumin in urine, and urine analysis overall. Primary aldosteronism, another very important factor, which is to be diagnosed in patients with diabetes as well as those who are developing hypokalemia in their younger age. Prevalence 8 to 30% in hypertensive population, and aldosterone renin ratio is giving the diagnosis of uh, this kind of the hypertension. Other endocrine causes like episodic headache, tachycardia, are seen mainly in the pheochromocytoma. Abnormal TSH are seen in the thyroid-related uh, hypertension, and hypercalcemia is mostly seen in the hyperparathyroidism, which again becomes the important reason for that. Missing a reversible driver leads to the persistent and controlled BP and unnecessary polypharmacy. When to suspect a secondary? If you find a patient with low level of the potassium with disproportionate high blood pressure, you must suspect primary aldosteronism. Creatinine rise after ACE inhibitor and ARB or any RAS blocker you are using, and still the creatinine is rising, then it raises a concern for the renovascular disease of hypertension. Paroxysmal headache. Sometimes excessive sweating, tachycardia must be patient evaluated for the pheochromocytoma. If the patient is having a lot of snoring, somnolence, obesity, and patient should be diagnosed for the obstructive sleep apnea with stop time. And progressive albuminuria on falling EGFR is the important thing to be diagnosed for the renal parenchymal disease. So let's talk about the sleep apnea, obesity, sodium, and alcohol. They all are the positive factor for the hypertension, which also stops the hypertension to get controlled despite taking multiple medication, and it becomes an important reason for the resistant hypertension. CPAP usually lowers the 24-hour blood pressure modestly in patients with obstructive sleep apnea, where adherence improves effect and justifies treatment for cardiovascular. If we find a patient of obesity, roughly doubles the risk via salt sensitivity and sympathetic activation, and many of the time aldosterone pathways are responsible. And weight reduction plays a phenomenal improvement in hypertension correction. Alcohol and nicotine, they have got an important role in increasing the blood pressure. Nicotine acutely elevates the blood pressure and cardiovascular risk. If we talk about the sodium sensitivity, it definitely matters in Indian perspective as well as in Asian perspective. In a crossover trial, reducing sodium from 5 gram per day to 1 gram per day lowered office systolic blood pressure by 22.7 millimeter of mercury in resistant hypertension. So target should always be there less than 2 gram sodium consumption in a day combined with the dash style diet. Dash style diet is that which is having at least 5 servings of the 100 grams fruits in a day. ABPM. ABPM is having a very important role in the diagnosis of the resistant hypertension as well as in follow. It's cornerstone for resistant hypertension management. Not only essential to diagnosis, it also helps in guiding the treatment, follow-up, and prevention. It distinguishes true resistant hypertension from white coat resistant hypertension and identifies mass resistant hypertension and office blood pressure that usually missed by the office blood pressure measure. So daytime BP evaluates the awake control, but the nighttime BP actually captures the nocturnal hypertension. Dipping status is only checked by the ambulatory blood pressure monitoring. No other method can usually see that what is the level status of the dipping. Higher variability adds the prognostic information, and that usually indicates towards the poor prognosis if the variability is lesser. Read more than the average blood pressure. 24-hour mean overall burden and treatment responses is 24-hour mean blood pressure is usually responsible for the overall burden, and it also impacts the treatment responses. If we know that what is the difference between the day and night, it separates the waking from sleep blood pressure load, and most of the time we also know about that whether the dipping is occurring in the night time or not. So dipping status is again important, and variability is another important. Good high variability is mostly seen with the good prognosis, but if the variability is poor, means if somebody is doing the exercise but his heart rate is not being changed much, and usually the patient is remaining in the tachycardia even at the rest, they are on the higher risk of the cardiovascular adverse outcome. ABPM distinguishes four practical phenotypes: true resistant, white coat resistant, control resistant, and mass resistant. Why ABPM is essentially useful for individuals with diabetes because it catches up the nocturnal hypertension. It also diagnoses the dipping status. It also diagnoses the mass hypertension and also helps in tailoring the therapeutic options like guiding in intensification, preventing overtreatment, and also support the adherence systems. So overall, if we look over that resistant hypertension. If it is uncontrolled office blood pressure, despite taking the three drugs, moderate or good adherence is there, then we can call it a resistant hypertension. 24 hours ambulatory blood pressure should be done in such kind of a patient. If there is white coat hypertension, then we can know about doing the ambulatory blood pressure monitoring. On the other hand, if it is not seen that white coat hypertension and true resistant hypertension is there, this is the time when we should look for another 24 hours ambulatory blood pressure monitoring. And if it is coming control after adding the fourth drug, then it can be considered as a control ambulatory blood pressure monitoring. Otherwise, we can call it uncontrolled ambulatory blood pressure monitoring, and fifth drug can be added to that. If still the patient is not controlled, then we call it a refractory hypertension, and we can ask the patient, and we can also send him to the higher centers for the management, especially to those who are having the research and their expertise in managing the hypertension. So stepwise monitoring of the pathways, confirm resistant ambulatory blood pressure monitoring with knowing about the adherence as well as proper measurement. On the other hand, it is not only sufficient to optimize the lifestyle with weight management, sodium control, diet, exercise, and also important to optimize the pharmacotherapy by RAS blockers and calcium channel blockers with diuretic. Diuretic is an important part of the treatment in the resistant hypertension. Search and treat causes like oral, obstructive sleep apnea, primary aldosteronism, renal cause or renovascular hypertension or any endocrine cause. It is important to know about the secondary hypertension. So escalate and refer is the last but not the least. If you do not find any cause which could fit in your treatment modality and as well as you don't get any line in give the patient treatment and patient is still not keeping control despite giving the medications more than 3, 4 or many more, then it is the time to refer to the appropriate center. Lifestyle optimization is not the optional, but it is the integral part of the hypertension management. This includes the weight loss, sodium, uh, less of the sodium with dash diet. Sodium should be less than 2 grams of the sodium in a day, and exercise at least more than 150 minutes in a week for a moderate exercise with aerobic activity. Pharmacotherapy includes that treatment. The start should be the core triple therapy that includes the RAS blocker, long-acting dihydropyridine calcium channel blocker, and diuretics that maximally tolerated dosage. Diuretic selection should be done with chlorthalidone or indapamide because they are the molecules which give the good correction of the hypertension of blood pressure in the condition of the preserved GFR. But if the GFR is not preserved, it is on the lower side, or it is on the reduced EGFR, in such kind of the two diuretics should be the better choice. Fourth line agent would be the high spironolactone or eplerenone. Pathway 2 supports the spironolactone as most effective add-on. CKD cautions that monitor potassium and renal function with MRA used in mineralocorticoid using diabetes and CKD. Diabetes note must be kept in the mind that RAS blocker is especially useful when proteinuria is. Transdermal clonidine may help when pill burden is a barrier to adherence. So there are the methods through which the resistant hypertension should be managed. That first of all, we should exclude the resistant. Then we should exclude the drug-related resistant hypertension. Then resistant hypertension should be confirmed whether it is actually resistant hypertension or not. In such condition, the intervention on the blood pressure should be done. If blood pressure gets controlled, at the same time, we should look for the causes of the secondary hypertension that includes the renal disease, renal artery stenosis, parenchymal disease, renal disease progression, endocrine causes that include the patient's hyper syndrome, hypo or hyperthyroidism, hyperparathyroidism, leukocytoma, primary hyperaldosteronism, acromegaly, and last but not the least, sleep apnea, that is also known as the OSA or obstructive sleep apnea syndrome. So screening is done appropriately for all these causes. As I already showing in the slide that for our renal disease, we should go for the renal artery Doppler ultrasonography, MRI, and renal ultrasonography, estimated glomerular filtration rate. Comorbidities should be excluded, and risk factors for the progression of the chronic kidney disease should also be sought. On the other hand, for the endocrine disease, serum and urinary cortisol is an important investigation to be done. Dexamethasone suppression testing to be done. Thyroid stimulating hormone, free thyroxine, thyroid ultrasonography, parathyroid hormone, serum calcium level, and plasma-free metanephrine for the 24 in the 24 hours urinary fractionated metanephrine should be done to know about the pheochromocytes. Adrenal CT also gives an idea about the hypokalemia, increased aldosterone bovine ratio, and also fluorocortisone suppression test is important to know about the endocrine causes of hypertension. Serum growth hormone during oral glucose load, serum insulin-like growth factors are another investigation which should be done. For the sleep apnea, it is Epworth somnolence scale stop time questionnaire should be used as well as with the polysomnography to be done. So these are the methods through which we can manage the endocrine hypertension as well as resistant hypertension. In the first step, we should exclude the other causes of the hypertension, including secondary causes, white coat hypertension, and medication-induced hypertension. On the other hand, then we should ensure the low sodium diet, which should be less than 2 grams, and maximize the lifestyle intervention, whatever we can do that includes the more than 6 hours uninterrupted sleep. Overall dietary pattern should be corrected, and weight loss should be ensured, and exercise must be ensured at least 150 minutes in a week. Optimize three drug regimen, as already discussed. One should be the RAS blocker, and there should be the long-acting calcium channel blocker, and third should be the diuretic. Substitute optimally dosed thiazide like diuretic, like with the chlorthalidone and indapamide for the prior diuretic. If the BP is not at the target, then add the mineralocorticoid receptor antagonist, MRA, like spironolactone or eplerenone. BP is still not at the target, then we should think about checking the heart rate. If it is not less than 70, we can add the beta blocker. And in such condition, beta blocker is contraindicated, then consider the central rifampicin. Or if these are not tolerated, consider once daily diltiazem. Then BP still is not the target, then hydralazine should be added in 25 milligrams 3 times a day. BP is still not at the target, then we can go for the minoxidil 2.5 milligrams 2 to 3 times a day for hydralazine, and titrate it should be the upward. Why spironolactone is pathway 2 evidence shows that spironolactone was the most effective add-on versus doxorubicin, bisoprolol, or placebo in resistant hypertension. Mechanistic analysis confirms the sodium retention in volume excess as central drivers, explains why mineralocorticoid MRA blockade works so well. Practical caution in diabetes and CKD: always indicate about the monitoring of the potassium, creatinine level, as well as look towards the gynecomastia related intolerance with the ongoing use. Ongoing monitoring and therapy under the studies are like repeat ambulatory blood pressure every 6 to 12 months when ambulatory BP is controlled. Monitor renal function, potassium, albuminuria, and end organ count. It should be monitored. Device-based therapies are those like renal denervation and carotid-based therapies should be can be used, which are still investigational. Radiance hypertension trial showed a modest 5.8 mm of mercury benefit versus the control. Now the renal denervation has been approved in Indian PCBI, so we can look for this device also. A specialist referral is last but not the least option. Summary and key takeaways for this talk of the resistant hypertension today in the global perspective should be excluding the first, the white coat hypertension. We should also exclude non-compliance or poor compliance. Look for the non-dipping in the night time, and mass hypertension should be diagnosed with ambulatory blood pressure monitoring before any patient labeling the resistant hypertension. Evaluate systematically by screening renal endocrine, sleep-related causes, optimizing the lifestyle and evidence-based triple therapy before escalation. Monitor longitudinally by using ambulatory blood pressure monitoring to reduce the misclassification, guide drug selection, what could be the best medication for the patient, and how can they be estimated for the cardiovascular and renal risk over time. In diabetes patients, coexistence of the albuminuria many of the times in the first day of the diagnosis is seen and CKD progression remains very poor. Autonomic dysfunction is another feature of the diabetes, especially in the long-standing diabetes when the duration of diabetes is very high. Vascular stiffness comes much earlier in the patient with diabetes as compared to the non-diabetic individual. And that makes the blood pressure control more and more difficult. Isolated hypertension is another problem with the diabetes individuals, which comes up much earlier to those patients and difficult to control. So whenever you try to reduce isolated hypertension, your diastolic blood pressure also goes down and sometimes lesser than the desirable limit. The consequences are more severe, and structured evaluation is not really the optional in patients with diabetes. Thank you very much for your time.
Thank you, Dr. Maheshwari, for enlightening us for the very important topic. We would like to now open the forum for question answers. We have Dr. Chong. Dr. Chong, are you there?
Hi, Saurabh. Thank you very much. I'm in the airport, actually. My plane is going to take off soon. I'm in Bhutan.
Okay.
But let me thank our speaker. Let me thank our speaker, Dr. Anuj Maheshwari. Thank you very much for your kind and very, very useful lecture. I was listening to it intently. Hypertension is something we encounter every day in about 20 to 30% of our patients in our clinic every day. So this is a very useful, good summary of some of the difficult cases that we usually see in our clinic. So excellent, up-to-date review of hypertension and the difficult areas. Thank you very much.
Thank you so much for your presentation. I appreciate the practical points as well as reviewing to make sure that you evaluate for secondary causes of elevated blood pressure. I think that, you know, it's always a system of like, here's our high blood pressure and here's your medication for it. But it's always important to make sure that we're excluding and ruling out other secondary causes. So thank you for a great presentation.
Dr. Maheshwari, we have a few questions on the Facebook. Take it and then we can wind up the session. Can insulin or diabetic medicines can affect my blood pressure?
Insulin has no direct effect on the blood pressure, but diabetes management has the impact on the blood pressure. If you are controlling your diabetes better, even your blood pressure would be having a good impact. And many of the times it has been seen that the patient comes with uncontrolled diabetes, and you control its diabetes and his blood pressure also comes down. And now most of the time these are very much correlated, because whenever the diabetes is there, blood thickness and concentration remains very high and blood pressure remains high. But once the glucose level comes down, then blood pressure automatically comes down. So always both the things are quite correlated with each other. Nowadays, so many medications like SGLT2 inhibitor and GLP-1 receptor agonist, they are also found to be having the good impact on the hypertension and blood pressure. So they are should be chosen if the patient is hypertensive.
Okay, and what about the kidney problems, the heart issues? Can they worsen up with this issue?
With hypertension, definitely the kidney problem and heart problem would be worsened. And if the patient is having diabetes and his hypertension is also developed, then his cardiovascular mortality and morbidity becomes more than double. In fact, it's not 1 + 1 2; it becomes 1 + 1 3 or more than that. And a more important thing is that hypertension mostly seen in uncontrolled diabetes. If a person develops the diabetes after keeping itself, it is uncontrolled for a longer time, then hypertension comes up. So if we control the diabetes since from the very beginning, many of the patients, we can stop the hypertension to occur.
Okay, great. There's another question which says, is exercise safe for me? What kind of a physical activity is recommended for if I have this issue? And is yoga safe for me?
Yeah, definitely yoga could be safe for anyone. As far as the exercise is concerned, exercise is safe for everyone whosoever can do, until unless he is not a heart patient or he has not met a MI recently, or he is having some heart failure kind of a situation. We can do any amount of the exercise. But those who are having these situations, cardiovascular ailment, those who are having, they should get done first their treadmill test, and after the treadmill test, they should decide how much exercise they should be done. Otherwise, exercise in terms of the walking is very safe for each and everyone.
Are there any questions from the audience here? Are there any questions, Dr. Elvin, Dr. Vineet? Do we have any questions, Dr. Prakash? So, Dr. Anuj, in the interest of time, I believe you are in US right now, and we don't have any other questions. The topic was well covered. We would like to end this session on a short note. Is that okay with you?
Thank you. Thank you. So nice of you.
So with this note, we'll close the session and see you again next week. Thank you.
Okay, see you next week.
Thank you.